If I don't hear or see anything.
There, sorry, I'm trying to get it to work.
Okay.
Okay, so we talked about this a couple times ago. So I saw this case. This was scheduled as a lung nodule follow-up. Um, and you can see this patient has all these tiny little nodules, like these little ones here. And I went back to an old abdominal CT from 6 years earlier, and the ones in the lung bases were there, and they're exactly the same. And so I said these are meningothelial-like nodules, and I showed a path case of one last time, and then we've talked about, is this something you guys are comfortable just calling? But I don't know. What do you guys think? I mean, there's some airway stuff going on, but if you've got these kind of tiny nodules, kind of all throughout, stable, especially over many years, I think we're pretty confident.
In a middle-aged or older woman in particular, yeah.
Yeah, but I think this kind of look to them is very characteristic. Okay, I just wanted to follow up since we talked about that. Here's a cool case. So this patient is a kidney transplant recipient and presented with cough, and you can see on the frontal radiograph there's an abnormality on the left, and we see some abnormalities maybe back there, but definitely something way down here in the left lower lobe. If you go back to the frontal view, you really can't see it, but I wondered if something was there, but definitely something down here, maybe something there. So did a CT scan, and we see a nodule there, and then this consolidation down there, which I think corresponds with the radiograph, and then a little bit further down as well, small pleural effusion. So, we've talked about this as solitary large nodule in a transplant patient with, this has some air bronchograms. Think about fungal infection, Cryptococcus was one. You can see of invasive fungus like Nocardia. Mucor, maybe Aspergillus. We don't include Nocardia in there, and then of course PTLD. So they did a bronch and a BAL, and this grew out Nocardia. And I know David recently showed a case like that, and then another one. I think that was going to be PTLD. So just another case, and it's when I'm starting to see this is when they're no longer on their Bactrim prophylaxis, because they're often on it for pneumocystis for the first year or so, and Bactrim will cover Nocardia in most cases. So something to keep in mind when they're not on Bactrim, throw Nocardia into the differential. Let me see. I'll just show one more. This was a pretty case. So this is a young guy with testicular carcinoma, sort of a mixed teratoma, and came in just for his routine follow-up. And he had just he'd been on I think 3 or 4 cycles of chemo with this radiograph, and you can see a very nice organizing pneumonia pattern. It does seem to have a little bit of small nodules associated with it, but pretty good perilobular thickening like that. This is from bleomycin, which he was on. Standard therapy for most testicular cancers is bleomycin. Surprisingly, he wasn't that symptomatic. I was kind of a little bit surprised, but this is one I see. It affects like 15% of patients on bleomycin, so I have a pretty low threshold to call this if I see what looks like an organizing pneumonia, and it can go on to fibrose. Now, why it's so nodular, I have no idea in this particular case why we're seeing that, but just something to keep an eye on. All right, I have more if we need to, but I'll go ahead and let someone else have a turn. All right, who wants to go next?
I can go if you want.
All right. Figure out I always forget how to change everyone's screen. Let's see. There we go.
Give me a second while this loads. This is just a interesting case that was done last night. I don't know why there's so many phases, but this is a patient with clearly has pulmonary hypertension and has very nice findings of pulmonary tension. And what's interesting here is has this in situ thrombus, which we see, and you can see the huge, they want to assess the coronaries in this patient. But let's look at what's fascinating about this is the prior study. So this, one second, hey, I'm on a webinar, just, so if you look at the study that was done a week before, so this patient had findings of massive pulmonary hypertension, but a week before actually had no in situ thrombus. So I always figured just that in situ thrombus was a kind of a very slow chronic process. Here's our delayed imaging on our study, where you can see the interval development of this in situ thrombus. Just within a week, you can actually even see some contrast imbibing between the in situ thrombus and the wall. So I've never seen it develop over a short period of time like that, let alone catch within a week it occur. I don't know, has anyone else ever seen that?
Had the person been on anticoagulation that was suspended or something like that?
Well, I think that may be the case. We have to look up the history if that was.
With that prosthetic valve, right? There's a prosthetic valve.
Yeah, they put in a mitral. It's actually a mitral clip.
Okay.
Understanding. But yeah, we have to check if they took them off anticoagulation. That was the cause of the interval development of the thrombus. That was just kind of a neat case. And then here's our first case of COVID here. So not the most, has some features that are kind of shown in all the different lectures and papers, but has some areas that I would say that are not atypical. Just I think this guy was, you would imagine, was sick for a couple days before he actually sought treatment, and he sought treatment because he passed out in an IKEA. So he was, sick for about a week, 5 days a week, decided to go out to IKEA, passed out. Someone called the ambulance. He came into the hospital, had the CT, and then tested positive for the virus, more that organizing phase of lung injury. But anyways, our first case here, I don't know if, the question is, we have the imaging patterns, and I'd be curious to hear what you guys are saying, because we're dealing with this right now. We have imaging patterns that are classic, and then we have imaging patterns that aren't classic. For the imaging patterns that are not classic, or, maybe, what are you guys telling your clinicians, or what are you putting in your official reports? Because we don't want every dictation to say, can't exclude COVID.
Right.
But when you have indeterminate patterns like this, this could be organizing pneumonia from anything. It's really not the most classic appearance. Do you say multifocal pneumonia and just leave it at that and let them figure it out? What are you guys doing?
I think it's a great discussion. I should all chime in. Jeff, what are you, because we just had a meeting about this morning, and I'll tell you what we've decided. But
yeah.
Anytime we see organizing pneumonia, we typically say causes of which include infection.
Right.
Because drug toxicity, and I think if somebody asks me, the answer is always yes, but in the right clinical setting.
Right. Because we're just trying to prevent people from saying, we were even creating almost like a UIP kind of thing where you have, definite or typical kind of looking for it, where it's, fits the pattern. If the history is, fever, concern for COVID, and then we have a bunch of cases that are not, the ones with extensive central ocular nodules, dense lobar consolidation, where we're just saying it's pneumonia. And then we have these cases that are non-specific of OP, which again, we're just saying is OP or DAD, and has a variety, just like Jessa has a variety of causes, infection, drug toxicity, so on and so forth. There doesn't seem to be any consensus about what people are doing.
Yeah.
Seth,
I was going to say, David, go ahead, since you have the most experience now.
Yeah, we've got 30 some cases now, and
really, oh, wow.
And I would say that it's often a patchy pneumonia, particularly in old people. And you wouldn't make you say COVID. You'd say there's a patchy consolidation and, you know, likely pneumonia, period.
That's exactly, that's what I told my guys to say.
Often looks like a bacterial pneumonia. And, you know, there's so many cases don't have that classic China look, that nice ground glassy stuff. A lot of them look a lot more like bacterial pneumonias with dense patchy consolidation. So I would not try to say it's a typical pattern. I think the patterns are a lot more various, and you know, there are multiple patterns here. I would not try to say it's not classic. I don't think that makes any sense anymore.
We're imaging the sicker patients here in the U.S., whereas in China they were imaging like mass imaging. And I noticed they also, many of the papers, they imaged people within just a day or so of symptoms, and then did serial CTs over the course of a week. Do you think you're seeing cases that are just more advanced because the patients are sick enough to present, and we're not mass screening everybody?
I think that's part of it, and I think the other thing is that a lot of the cases that I'm seeing are in old people.
This guy's 40.
Yeah, so I think it may be different in old people, and may look, you know, maybe denser and stuff like that, and look more like a bacterial pneumonia, maybe because of age. So I think it's what time are we getting the imaging, and then how old is the patient, and what sort of an immune response is the person generating. So I think it's both things, Jeff.
Okay.
Yeah. And I think a lot of it is when we're getting the imaging. Again, this guy was probably sick for a week or so.
Yeah, Travis, how are you guys handling it? You said you had a meeting about this.
Yeah, so we had a meeting this morning. Our consensus is to, you know, the patients that look like organizing pneumonia, is to just say organizing pneumonia in the report, and say, you know, this can be seen in the setting of pneumonia, including viral. Then have a call with the clinician where you don't put coronavirus or COVID in the report.
Oh, so
and I think that's kind of what Seth is saying too.
Yeah, no, it's interesting. So we're maybe that's even a better idea, because for the ones that are classic, like the ones that are coming out of China, where their history is, you know, a lot of times we're getting histories rule out COVID. I mean, literally, that's the history we're getting on some CTs. And if they have the classic appearance, we say finding can be associated with various infections, including COVID-19, only if it's their clinical question and it's classic. But and we call them and give them a call. But maybe we should just say viral pneumonia and not specifically say COVID.
Yeah.
And give them a call anyways. I don't know.
I really like this example, and I think that this is one of the big complaints I have with some of the literature that's coming out so rapidly, like the recent one comparing COVID to other viral pneumonias. It's an artificial population, because especially with us, you're going to be comparing COVID to patients on Pembro that have a drug reaction, and you know, your specificity is going to be, you know, a coin flip if you put this patient up against one that is on Pembro and has a drug reaction with organized pneumonia.
Yeah, for sure.
So what do you do for cases that are not classic, like this? I mean, I'm just telling our guys to say it's organizing pneumonia for, you know, most causes include drug toxicity, infection, so on and so forth. Or if someone even has DAD as an inpatient, don't say DAD. Don't go, just say it's DAD, and there's various causes, and that's it.
I don't think it matters, because at least here they're like the ACR said, that this requires PCR confirmation. So these patients are going to be on isolation and rule out regardless of what we say, I think.
Right. I just don't want every person that has like a, you know, lobar pneumonia, not people in my section, but, you know, we have a lot of people at ERPM reading stuff from 5 to 10 and, you know, calling every pneumonia COVID.
Yeah. And I think that gets into the third category, which is features that haven't been classically described, like lobar consolidation, nodules. I'm curious what David has to say on that, since he's seen so many and he's seeing the sicker patients. Are you starting to see some of those other features that we typically see in patients with bacterial pneumonia or other pneumonias that hadn't been described in these earlier series?
Well, a lot of the times we have just chest X-rays, because we're not using CT for screening, and we're only doing CT as if there's some specific indication to do CT, such as you're looking for a superimposed pulmonary embolism.
You're actually following the ACR recommendation. That's amazing.
Well,
How'd you get your clinicians to buy into that?
We did not consult with them, but that's what we derived here, and that was with consultation with our ICU pulmonologist. And so we decided that CT is not to be used for screening. We basically get CT scans or chest radiographs for the same reason we would get them for any other ICU patient with an infection, which is is it going to change diagnosis, or is it going to lead to some therapy? So that might be some complication.
Right.
A person's getting worse or something like that, or has new set of symptoms, or a person might have a pulmonary embolism. By the way, COVID predisposes to pulmonary embolism. So it seems to predispose to thrombosis and stuff like that. So if somebody is in the ICU and they're doing okay and they're suddenly worse, there could be a PE, and that might be an indication to do a CT directed at pulmonary embolism. And so a lot of the cases I've seen, I just have plain films. They're old people and they've got patchy pneumonia. It's in upper lungs and lower lungs. Sometimes it's just on one side. You think if this person came in the old days, you'd say this looks like a bacterial pneumonia, or sometimes it's in the base and you'd say it's a bacterial pneumonia, or it's aspiration. Sometimes it's widespread patches and stuff like that. It's not been diffuse and ground glassy, at least as you can determine ground glassiness on chest radiographs.
But we all know it's that hazy stuff. Not supposed to call it, but we kind of.
Are you seeing? But like one thing we talked about is like if you see what looks like your classic community-acquired infection, like in an older person, say like a lobar area of consolidation with a pleural effusion, are you seeing those on the radiographs, like at the acute presentation?
No, I've not seen those in any COVID patients. As a matter of fact, I don't think I've seen pleural effusions in COVID patients. So if you've got a single lobar pneumonia or something like dense pneumonia, I don't think I would bring up COVID.
Right, and I think that's a point. Like if we do see that with a pleural effusion on a two-view chest, I think there you can say consistent with infection, and almost. I think that's where it's useful, is saying, okay, the likelihood this patient has COVID-19 accounting for their symptoms is actually very, very low.
Right. But has anyone talked about like flu, we always get super infections with MRSA. Has anyone seen super infections, bacterial infections on these cases yet? Not
that we've recognized.
Okay. I've seen one case that was shared with me of a patient that was pretty sick that had a really dense right upper lobe consolidation, pleural effusion, was COVID-19 positive, but was quite a ways out from when they originally got sick. And I'm convinced it was a super infection, but it had been on antibiotics already, so they couldn't culture anything. But it looked like nothing that had been reported. And had we seen it in any other context, we would have said it looked like a bacterial infection. So I've seen at least one presumed case, and I'm sure there were plenty in China that no one's just reported them yet.
Got it.
Yeah, no, it's just the logistics. Like even like if you see a case that you think are you guys calling the CT scanner and saying, hey, don't scan any more patients on there because you're the first one really to see and diagnose the images? Are you even taking that responsibility? What?
Well, fortunately, we haven't gotten to that point yet, because the few that we've scanned so far have been ones where it's at least suspected and they're coming in on precaution anyway, and the scanner's getting closed down, regardless of what we see or say.
So that's a good point. What we've decided here, and this was also our consultation with the ICU people, is that we will use droplet protection, but not aerosol protection. That means that if this were aerosol protection, that's what you would use in a CT scanner if you had TB. So TB patient, they're gonna do 5 air exchanges in the room. They're gonna bring in these HEPA filters and stuff like that, and the room is going to be decommissioned for 90 minutes or 2 hours. But we're just doing droplet protection. The patient comes down with a mask, and then we just swab surfaces within 6-foot radius afterwards, and that means that the CT scanner room can be repurposed, mobilized again very quickly. So droplet protection is a handier way than aerosol protection for returning the CT scanner.
Has the CDC finally said it's not aerosolized, that it's a droplet? Because I know that was like the big thing, because the CDC hasn't officially said that it's, even though all the other countries have said that it's a spread via respiratory droplets.
Right.
You know,
Well, that is the decision here based on, based on the expertise of our pulmonary people and ID people.
yeah.
So, Seth, to that question too, I mean, I said most of these patients, are suspected and appropriately precautioned ahead of time. And with last hour, and I'm not making this up, we had a patient who's an outpatient that had a breast MRI for screening 2 weeks ago, never had cancer, and had some consolidation in the left upper lobe. Now gets a CT today, and they've got clear-cut organizing pneumonia that's waxing and waning. We have no cause, but they're asymptomatic. It's like, what the hell do you do in those situations?
Yeah. No, we had one the other day, same thing. And everything was kind of shut down. And then they realized that the patient's eosinophils were 40%, and she had chronic eosinophilic pneumonia confirmed on bronch. But it was, a classic peripheral OP pattern in a young patient with a cough. So, we're just, I feel like we're in the early stages of the NSF issues when that all rose, and just shutting everything down and going a little crazy until we figure this out. But it's a good discussion. It would be nice if there was kind of a recommended policy or verbiage or something, because again, the last thing you want to do, and I've talked to people who are like us, have people reading overnight, or from 5 to 10 who aren't chest guys, and they're calling just everything COVID, or can't exclude COVID, and that's like the last thing you want.
Right.
Steve Hobbs from University of Kentucky told me at STR the other day that happened in like a rural Kentucky hospital within the last couple of weeks, and basically shut the hospital down.
Yeah.
It was one of those, so you can't exclude COVID, and of course probably hasn't made it to small Midwest communities yet, but who knows? But yeah, I agree. I think we all agree here it's not helpful to include the term in the report. Call and communicate that if there's any suspicion.
Yeah, maybe I'll change that. Maybe that's a good idea, just to change COVID-19, to viral pneumonia, and just make it a phone call in the cases that are, even very, very typical.
We don't want to box them in.
Yeah.
Right.
Yeah. And that was our whole discussion about only doing that for the cases that are like textbook in the patient who they're concerned about. But even if there's no reason just to not just say viral pneumonia.
I mean, honestly, if they're concerned about the patient, they shouldn't even be CTing them.
Yeah.
So, Seth, I wouldn't even confine it to viral pneumonia. I would just say pneumonia.
Yeah, pneumonia, but including viral.
Including viral, but not.
Yeah. Something.
Right. So another question, like with our outpatient that has organizing pneumonia and is asymptomatic, I'm unclear, from these large populations that have been studied, like if you see an organizing pneumonia pattern and a patient is asymptomatic, what's the likelihood that it is actually COVID? Are there patients that are asymptomatic with lung abnormalities, or do we know yet?
I don't think we know.
There were some cases of children in Wuhan. I think with that early series, it was like a family of 7 where there were 2 children. One had normal scans, one had an abnormal scan, but I don't think had any symptoms. But not aware of any adults.
Well, I think it's probably the case, because I mean most cases are mild and people might not even be aware. So I think we ought to presume that there are going to be asymptomatic carriers of this condition, because there are people whose symptoms are so minimal that there are probably going to be some people whose symptoms are 0.
Yeah, for sure.
All right, and then it's a good discussion. And the last case, this is kind of interesting. See what you guys think about this. The advantages of portal venous phase. Anyways, so here's a guy, who came in quite ill, has colon cancer, has this very nasty pericardial, pleural effusions let alone, but this really nasty pericardial effusion. You can see, On my other computer, I had the echo pulled up, which you don't need an echo to show that the tamponade. I mean, this thing is dramatically compressing the ventricles and the left atrium. And so the guy had tamponade. So here, let me show you his CT from about a few weeks before, which showed no effusion, bad disease, this very nasty liver thing going on. I don't know what that is, just tumor and necrotic stuff. Anyways, let me show you the belly study, because I think, again, the advantages of portal venous phase are really, when you're especially looking at the pericardium, quite amazing. So you can see that this is a very nasty pericardial effusion. I thought it was going to be a tumor in here, causing this kind of inflammatory pericardial inflammation. It turns out that they tapped this thing and got out Klebsiella and some other species. So it was actually an infectious pericarditis. But the interesting thing is, so initially they kept thinking it was an esophago, that there was a fistula between the esophagus and the pericardium, which, because these are flora that usually live in the esophagus, didn't really see evidence of that. It's hard to tell, but there is this very strange kind of fluid collection, which is contiguous with the biliary system, that's kind of causing this large area of hepatic necrosis, and that is contiguous with the pericardium. And we were wondering if this could actually be a kind of a pericardio. You can see even there's this subhepatic abscess, and that all of this kind of looks like in certain areas that it's communicating directly with the pericardium. So we were wondering, so we asked them, could these species that were pulled out be seen in the biliary tree? And they said yes, in certain instances. So we were wondering if this could be a biliary, because there was all this, they did a partial epitectomy and there was some biliary leakage. Anyways, a biliary pericardial fistula. But I had not seen that before. But it's just a case of a nasty, again, I thought it was going to be malignant pericarditis, but in fact, it was infectious, causing tamponade. Anyways, not COVID.
Cannot rule out.
Cannot rule out, can't exclude COVID in the pericardium. But yeah, those are my cases.
All right, thanks. All right.
Jeff, can I go really quick?
Yeah. There you go.
Before we have to start scanning more potential COVID cases. You guys see a radiograph that's now slightly better windowed? So yeah, this is a 46-year-old who is one of our first confirmed cases. And much like David said, we're not getting CTs in these patients, but I show this just because this is more, this guy's teetering on the brink of ECMO at this point, and was sick for 2 weeks in the community and has no known contacts, no travel. So of course, this just looks more like lung injury. Some of the areas are a little bit more nodular. Was asking if they thought he had a superimposed bacterial pneumonia, and they said no. So yep. This is a confirmed COVID radiograph of somebody who's deteriorating.
And it looks as if he may have pleural effusions too.
Perhaps, yeah, actually he probably, I wonder if he has a rib fracture there right down. Like if he's, I don't know if he's had to be resuscitated yet or not, but yeah, especially on the left there. So this was one of the questions I had coming out of the STR meeting, because a lot of what we're seeing, like Jeff was saying, is earlier disease. I was wondering, you know, the patients that are going downhill, what do they look like? And as you imagine, they look like this. This is one, I know Howard's not on, and this is, Howard had showed a case a couple weeks ago. Let me make sure I get the time of these right. He had shared a case with some of us, so I don't think he actually showed it, but this is a patient who has pretty exuberant ossification here. So the question is this all just related to his fibrosis, or could it be a concomitant amyloid? This guy certainly has fibrosis, and he has traction and reticulation. And it's nice because you can see in 3 years how this has progressed significantly. But I would say this is probably just all due to the fibrosis, since the fibrosis is worsening. And I know the one he sent out was even more exuberant than this, but I looked through some of our cases of confirmed amyloid, and I've never seen one that followed like a peripheral and subpleural distribution exclusively like we see with fibrosis. Because I know we keep mentioning that amyloid is in the differential, but certainly that would, if it really is in the differential for a look like this, then that would have significant implications for the patient, right? As opposed to just dendriform ossification.
Have we seen cases that look like this that are amyloid that we have?
No, that's my point. I haven't, and I'm just curious because I know that often gets raised in the differential.
I think that's particularly in the cases that don't have a background of fibrosis. This person has a lot of fibrosis.
Right, because there's that nice article from, was it Radiology a couple of years ago? It was like one of those things that you love when you see an article that actually kind of
is this the one that Gruden wrote in HAR on?
No, it was actually, I think it was done at Mayo or even UCSF. I don't remember where it was, but they looked at like 100 people with dendriform pulmonary ossification and with fibrosis, and like something like 85 or 90% of them had UIP pathologically. So it's a very good kind of marker if you're questioning, well, is this potentially, fibrotic NSIP or UIP? If I see this finding, not as even more mild than this, just a few areas that are clearly dendriform pulmonary ossification, it definitely makes me lean towards or I'll come down stronger on UIP if I see this finding. And that had been my experience, and they very nicely showed that in a nice RadPath paper.
Okay, yeah, I don't think it was from here. And then there was the more recent one that Gruden published, where they looked at dendriform ossification without fibrosis, and a lot of it was aspiration related. And I've shown a couple of cases of that, but I don't know if I've ever seen, even if you subtracted the fibrosis, I can't think of a case of amyloid I've seen that had a subpleural distribution like this. Because I was looking through our teaching files, and a lot of them are more like just central or diffuse. So I don't know if you guys have any examples of confirmed amyloid with a similar distribution to this.
I've never seen that.
No, that's just food for thought. And then this one really quick. So, this is a spectral CT, and we don't do that much dual energy. And Seth, do you guys do spectral CT too, or is it just dual energy? Or
well, the spectral CT technically is only on a Philips.
Yeah,
and we don't have that.
Okay.
I'm a huge fan of it. I would love to get it, but yeah.
So this was one from our VA, because we have a Philips scanner at the VA, and you can see this transient interruption of contrast. And so we tried the spectral, and I'm going to point you to the right middle lobe pulmonary artery here, because this is the spectral CT, and they're monoenergetic 40 kb. And so, based on this, you'd say there's nothing here, and that this is a pretty good look at the pulmonary arteries, even though they're contrast bolus, you're looking at it was under 100 Hounsfield units in the pulmonary artery. So this was called negative. And then of course, later or the next day, the patient gets an abdomen and pelvis CT. And here you can see that there is unquestionably a pulmonary embolism right here now. And the question is, was it there on this study the day before, or is this really just is this a pitfall of spectral CT where it actually doesn't, perform like it is supposed to in a case like this? Because the pulmonologist was convinced that, whatever happened before the PE study. That's when the patient became tachycardic, and they were really stable between this study and then the abdomen and pelvis CT. So I'm trying to rectify this. Any thoughts?
And can you show the original one at not 40 KE?
Okay, sorry, I'll show the original one. What did you ask, Jeff?
I was going to say, so because on one of our scanners we have the KV switching, but we get the different series. We get the standard, we get the monoenergetic. Did you only get this one series?
this is the original study. This is the monoenergetic study. I think this is all we had. So Seth, here it is. What was your question, Seth?
What is the spectral image show? Is there a perfusion defect there? I would assume there would be a perfusion defect if.
I don't.
So go up higher. So it was right. It was, what was it? Right middle.
It was right middle lobe. It should be.
And it was medial segment, so it should be. Well, I don't know.
Yeah.
So is that normal middle lobe perfusion? It seems to be. There seems to be.
It's a little less, but it's kind of similar to the lingula there. I don't know. We just don't.
By the diaphragm, it gets tricky.
Yeah.
You would have to follow out that vessel. It doesn't look too egregiously abnormal there, but you'd have to follow that right middle lobe vessel out. It could,
Yeah.
That's interesting. I don't know the answer if that's
Okay.
My guess is it was probably there, but I mean, you really don't see it. It's pretty, you really don't see
I don't know. So, okay, I'll stop there.
Oh, so the paper I found, it's diffuse pulmonary ossification and fibrosing interstitial lung disease, David Hansel and Ethel Wells and Andrew Nicholson, so different country. But it was in 2017. And they talk about its association with fibrosing lung disease, how much more common it is in UIP, so.
All right. Peter, do you want to go?
Sure, I can go. Sure. So this is a young guy. He's in his 20s, but he had a sudden onset headache, and this is his head CT when he came in. So you see this intraparenchymal hematoma. It's pretty large. So he has a history of factor V Leiden and protein S deficiency. He's on Eliquis, and this is his chest CT. So this is a pretty classic, I thought, some classic findings of CTEPH. He had some on the right side, trying to find them, but he had some. Right there, for example, some thin fibrous web-like filling defects, a little bit on the left. Some evidence.
Yeah, could you see a PFO?
I don't think so. There's too much motion. No, I think he got the hemorrhage in I thought the parenchymal hemorrhage in the brain was from his Eliquis.
Okay.
But I'm not sure. He has some large bronchial arteries, basically the findings of CTEPH, and some mosaicism.
So he was on Eliquis because of atrial fibrillation, or?
I'm actually not sure why he was on Eliquis. I have to look that up.
Okay, I wonder if, I mean, I didn't know that.
What they were. He must have been. I wonder if he was on anticoagulation for his factor V also.
Okay, so that one makes sense.
Yeah. Okay. This is a quick case of. This is a patient with tetralogy of Fallot, and he had a anomaly here in his coronary sinus. He has an atretic coronary sinus, which doesn't you don't see a connection to the right atrium. And he also has a apparent SVC on the left side.
So Peter,
Yeah.
I've been waiting for a gated case like this because I've seen this several times now. So this is like, because it's not truly a left SVC. I've shown non-gated cases of this. This is a vertical vein, you know, that is decompressing the coronary sinus.
Yeah.
This is at least my theory in these cases, because this is one of those ones where, you know, that if they ligate that, the patient can end up with ischemia.
Right. And I couldn't actually completely follow that vessel right there all the way down. You kind of lose it as you go inferiorly, right around there.
Yeah, it's got to. I bet it's still there. Well,
but it's still there.
I see what
Yeah.
you're saying in this case, yeah.
Yeah. But I think it continues right there, and it continues into that coronary sinus. But you can see there's no connection there.
Yeah, and speaking to that, where is it? It's draining for the middle. Is there an accessory drainage for the inferior interventricular vein? Follow that down. Follow that guy out. Where does that drain? Because the answer is that your coronary. I have cases where you have severe stenosis of the coronary sinus after intervention or something. If there wasn't drainage of that via either that other vein or this vein potentially, there would be a lot of issues. Coronary sinus would be absolutely massive. So it has to have some accessory collateral pathway of drainage, because that's not even that.
Yeah, but I couldn't see anything else draining into the RA. Yeah, I was thinking the same thing.
Yeah, but that might come up and drain into the go around, drain into that vertical vein, then go into the brachiocefalic, and then the SVC.
That's the only other. Yeah, that's the only other pathway. Yeah.
But it's interesting.
Okay. This is a strange case. So this patient had a couple months ago, maybe 2 months ago, he had a stage 1 adenocarcinoma in his left upper lobes, which I'm not showing because that's kind of irrelevant in this case. But so he had a left upper lobectomy, and then this is his post-op scan. I want to say a few weeks after his surgery. You can see there's looks like there's a bronchopleural fistula here. You can still see air. And then so look at the follow-up scan, I think a few weeks after that. Again, you can see there's let me just fix this 1 second, sorry. Okay, so here it is. So this is the follow-up scan. There's increased pleural thickening, and again, you can see the connection right there. This is a bronchopleural fistula. And now there's this other abnormality here, this vascular abnormality. It looks like a pseudoaneurysm. And the person that read it, and I would have said the same thing, is I would have thought this is a pseudoaneurysm arising from probably an infected pulmonary artery. And so you'll show the, let's take a look at the angiogram here. So you can see them getting to the right, into the left PA here. And here are the vessels, but that pseudoaneurysm is not showing up at this point. And then so as you get into later phases, you can see the perfusion into the pulmonary capillaries and veins. And then eventually you get the systemic circulation here. And as you keep going, you see the subclavian arteries faintly opacified, and you see it right there. So it turns out this is actually supplied by the systemic circulation. And then so here's on a same study, they did a follow-up run. You can see them here into the subclavian artery.
Yeah, you can look at his case. I think great.
And I thought I saw it on, yeah, you can see it right there. So this patient developed, and I hadn't seen this, they developed this, all this neovascularity here, going into the lung from the subclavian artery, including the pseudoaneurysm. And so they coembolized the branch of the axillary artery, the lateral thoracic artery here, and they thought that would fix it. But then a follow-up CTA shows that it's still getting perfused, and so they had to go in again another time, and then they embolized the internal mammary also, and I think one other vessel here branching off the subclavian.
Interesting. It looked like on the first angio, was it draining somewhere funny? There was some big vessel draining centrally. When you let's see.
Yeah. So the first one is this one. So the one from the pulmonary.
No. The systemic arterial.
Yeah. Okay.
Yeah.
Yeah, you kind of see it, but it's really late. I'm not sure.
Right. You see that kind of.
But it's right there, actually.
Right. Yeah. Right. It's really down low, just below that big tangle of vessels. There's looks like a big tortuous vessel draining back towards the mediastinum.
Yeah, you wonder if that's a pulmonary vein, but I agree, it does look a little.
I was just curious if they sorted out what that was.
You see it on the CT?
CT. No.
It's probably the pulmonary vein.
Yeah. Yeah.
Well, that's interesting. I don't think I've ever seen one of those before in a resection cavity.
Yeah, and I never see. So this was what I was wondering. Have you guys seen all this neovascularity develop from? Because you can see how much vessels are coming down from the. So all these collaterals that develop from the systemic circulation going down into the lung, and I'm not sure it's because of the inflammation that's there. That's the only reason I could see that all those vessels getting recruited in there. And then that's it.
All right. David, did you have any cases this week?
Besides COVID, no.
All right. We can end up here and resume next week. Thanks, everybody. If you have any more thoughts on the verbiage for COVID, please share with the group so we can try to. Yeah, I think we're all on the same page. Just don't want to.
Yeah, no one really knows what to say, and people keep coming to me like, "What are you saying?" And I'm like, "I don't know. I mean, what I'm saying probably wrong." So that's why I wanted to bring it up. So yeah. I'm glad.
Good discussion.
I'm not completely off, but thank you.
Yeah. All right. Take care, everybody.
Thank you. Bye-bye.
Bye.